Hi, I'm Haley Muto, and I'm thrilled to be hosting this year's Spokane Regional Health District's Opioid Task Force community event. We have a wonderful wealth of knowledge lined up for you and hope after this hour, you'll walk away having learned something new and join us in advocating against the negative stigmas attached to opioid use disorder. Our first guest is Dr. Scott Phillips. Dr. Phillips is the medical director for the Washington Poison Center. He has over 30 years of experience in researching, treating, and teaching about drugs of abuse. Dr. Phillips, thank you for joining us. I'd like to hand it off to you to share the slides you've prepared to share.
Okay, thank you. You're going to bring my slides up now?
Dr. Phillips, you should be good to go.
Okay, I can't see the slides on my end. Can they be shared or?
I think they're broadcasting the slides for you, so you can just start presenting, and as you'd like to go through the slides on your end, you can just say next slide.
Okay. All right, give me 1 second. I'll have to pull it up on my end because I'm not seeing them, so I can't tell you when. Make sure the right information goes to the right slide. But I want to thank everyone for inviting me to speak tonight about this really very important topic. Sorry for this little technical glitch here. Let me just find that slide. Okay, I want to speak to the community, and I want to thank the Spokane Regional Health District for putting this presentation together. It's a very important topic, I think, and I really want to speak about fentanyl, both in regards from the national perspective, but also from the perspective of us in Washington State. And at the Washington Poison Center, we collect information regarding fentanyl, primarily on acute exposures where people have not passed away. That's just the nature of our business. But we have a lot of information I want to go over with you regarding that. So next slide. So fentanyl is an opioid, and opioids are drugs that work at very specific receptors in the brain, and there are several of them. And fentanyl goes by many different street names, and you can see a list of the street names down in the bottom there. And so one big question is, gee, where's it coming from, and are there increases in Washington? And there certainly are increases, both in use, exposures, and in deaths. And we'll show some data in a minute regarding the state and Spokane County as well. Next slide. So fentanyl has an interesting geoglobal distribution. Primarily, the precursors originally started to come from China, being exported into Central America, where it was finished product and then shipped in. Alternatively, there's labs in Asia that also produce fentanyl purely and export the final product as well. That's changed a little bit, and some of the cartels in Mexico have been actively involved in producing this. And we're seeing a bit of a shift and an upturn, according to the WHO Center on Drugs. And Afghanistan is actually creating some labs, clandestine labs there as well. And we're seeing some exports from Afghanistan through Iran and then off to other parts of the world. So it's a bit of a changing pattern, primarily because fentanyl is quite easy to manufacture. So that's part of the distribution funnel that we're seeing. So next slide. So this is a slide that shows in the upper left corner fentanyl exposure cases that are reported to the Washington Poison Center over the last many years. And this slide goes from 2010 to 2020. And you can see the total number of cases has gone up significantly. Now, the number of cases is not large that we see at the Poison Center. Remember that these are cases that are complicated cases where the treating physician, typically in an emergency department or intensive care unit, isn't quite sure what to do. So it's a little bit of a selection bias on these. So these are kind of the sickest of the sick patients without really having passed away. And you can see in the image right below that left graph, you can see the amount of heroin versus the amount of fentanyl. The comparison of how much it takes to get someone high. And that's really important because fentanyl is up to 100 times more potent than morphine. And the idea is that it's easier to transport smaller quantities and essentially get more bang for your buck. And that gives you a visual representation about how much is there. The slide on the right side, the figure on the right side, shows fentanyl exposures from 2020 in red and 2021 in blue, and that data is only up through August. And they're small numbers, you can see there, so they do bounce up and down a little bit because it's only a partial year. So next slide. It's interesting to look at fentanyl exposure by age groups, and this is just a 3-year snapshot looking at mean ages, the average age of people that we get calls about. And the range in years, in other words, the youngest to the oldest in each age group. And you see the mean age is really very similar. These are early 30-year-old people primarily that we get calls about at the Poison Center that are using fentanyl. But it does affect all age ranges. And if you see on the very right column there, you'll see the range in years. And you can see in 2019, the youngest was 3 years, the oldest was 74. 2020, 1.5 years, the oldest 72. And this year, the youngest is 9 days old, and the oldest was 77. So it is kind of shocking and disturbing, but it does happen frequently. So it affects all age groups, and that's an important thing to recognize as far as being aware of it, but also treating it. But the mean age group, the primary people we get calls about are in their early 30s. So next slide, please. So I mentioned a minute ago, about the amount of fentanyl that's required to cause intoxication in someone. It's a tiny, tiny bit. And it's really dangerous because you have to remember this is illicit production, right? There's no quality control being performed here on this. And so the actual potency can vary. And not only the potency of the fentanyl being created, it's really more with how much other ingredients are mixed with it. And as a drug goes from its source to the street, it goes through several steps where dealers will mix it with other ingredients, and that's called stepping on the product. And so they step on it to make the more volume, more volume, and more volume. And that just creates an unknown amount of a substance. And so the quality is really difficult to tell. So there's really no QA, QC kind of procedure, obviously, with street drugs. And that results in a variable dose that people might get into, which really creates a problem. And so we really think about looking at the patient more than looking at the particular substance they took, because oftentimes what they say they took is not what they really took. And part of that is with unsuspecting users. People aren't always aware of what they're getting. They might be thinking they're getting heroin, but in fact, they're getting fentanyl. Fentanyl costs about 1% of the cost to produce heroin. If you look at the toxicoeconomics of this, of illicit drug production. So fentanyl is very inexpensive to produce. It's very potent, so a very tiny amount of it goes a long ways. It also comes in the form of counterfeit medications. We see it marketed as Oxy on the street, and it even comes in blue capsules like 30 milligram OxyContin tablets, and you see pictures in the slide there that resemble those. And oftentimes they also go by the street name Mexis, M-E-X-I. But that's kind of why fentanyl is so dangerous. It's very potent. And most of the users are unexpecting. They're not aware of it. So next slide, please. So as I mentioned a moment ago, the potency is about 100 times more potent than morphine. But it's not just fentanyl. Fentanyl has many cousins. And we call these cousins analogs, which is just a fancy name for related substances. And carfentanil is another it's a veterinary product used for sedating very large animals, like elephants, for example, is where it kind of has a street name from. And carfentanil is about 10,000 times more potent than morphine. And carfentanil is being seen, and it is being seen in the state of Washington. Still not as prominent as fentanyl, but it certainly is available. Again, it's manufactured. It's easy to manufacture. It even takes, 1,000 times less of that than fentanyl to cause the same amount of intoxication. So, you get more bang for your buck. And so we can expect to see this because it's far easier to smuggle in, harder to detect. And we're going to see a lot more of that coming in the future. And there's probably a half a dozen, at least, other fentanyl cousins that are out there that we see in the United States. But carfentanil is really the one that's making the biggest approach right now. So next slide. And this is a closer picture of some of the fake medicine, the OxyContin mimics, also called fake oxys or mexis. And we see these daily as far as calls to the poison center. These are very widely distributed, and quite often this is the form they come in. It's not as common that people inject fentanyl, but it does happen. Primarily, the drug abuse on the streets is with the illicit tablet forms. Next slide. So fentanyl distribution. So there's kind of a terrifying trend going that we're going to talk into a minute about how fentanyl is being distributed, and social media is really playing a big role in this. but also e-commerce, the dark web, and they are taking advantage of existing distribution networks. If we look at how this is smuggled across borders and then distributed throughout the country. So these fake pills and or just fentanyl powder is widely available. And I just show you some chemical structures there of 3 other fentanyl cousins. So you can see the chemical structure looks very similar, and a few little red sticks on the side that show you the difference. So they don't have to change these molecules very much to make them either more potent or longer acting kind of product. So it's common to see these little changes to the molecule of fentanyl coming out. So next slide. So if we think about fentanyl, fentanyl is an opioid. It's synthetic. In other words, it's man-made. It doesn't occur in nature. It is a narcotic medication. In other words, it's narcotizing. It puts people to sleep. It works at the same receptors in the brain that morphine, that codeine, that many other pain medicines work at, primarily the mu receptor, less so the kappa receptors and some other sites. But these are all responsible for causing the respiratory depression, the shallow breathing, stopping of your breathing. That's really related to this mu receptor in the brain. And that's what our target is, both for the fentanyl, but also for our use of naloxone to reverse this. So that's an important focus to remember. Next slide. So if we look at United States data versus Spokane County data, we'll come to Spokane in a second, but this slide looks at U.S. data. So all over the U.S., fentanyl deaths per 100,000 has dramatically increased in the last, primarily the last 5 to 6 years. And we see in Washington State that's a bit of a slow lag behind that, but it is picking up. And this ends in 2018, and it's essentially gone straight up since 2018. And this year already in 2021, we've already had over 100,000 overdose-related deaths in the United States. And these really are the majority of them related to fentanyl. We used to think it was more oxy, but when you test a lot of these samples, they really are fentanyl that are causing the deaths. So about 70% of those deaths are thought to be related. And that includes, many common things like other antidepressants and aspirins and other things that can poison people. So it is quite a dramatic number. So next slide. Well, I mentioned social media as a way of distributing medications, and this is kind of a shocking revelation that's got a lot of attention this fall. And this is a picture from a Snapchat image from the United Kingdom, where it lists several different kinds of illicit drugs for sale that you can buy on Snapchat, like LSD and MDMA, and shatter, which is essentially like hash oil. It's condensed, ketamine, Xanax, propofol, which is a sedative that we use for anesthesia in the hospital, as well as marijuana. But the idea here is that you can place your drug order on Snapchat and it will be delivered to your home. And there's been quite a number of teenage deaths from teenagers placing an order on Snapchat in the United States. Medicine gets delivered. They don't know what they're getting, of course, and suddenly they're found, dead in their room. And so there's been, if we look at the next slide, there's been a big push because there was a gigantic uproar about Snapchat not doing enough in this. And so Snapchat has really come back trying to knock this down and counteract people buying drugs on Snapchat and having them delivered to your home. It's essentially like Uber Eats. Instead of food they're delivering drugs to your kids at their home. And that's just really a tragedy. So it's just something to be aware of that's out there. So next slide. So if we look at Spokane County more specifically, and this goes back to 2018, that first column is as a typo. We look at methamphetamine, heroin, fentanyl, and then the exponential curve for fentanyl. And you can see the light green is methamphetamine, the darker green is heroin, and the red is fentanyl. And you can see over the years that fentanyl has taken off in deaths related in Spokane County. And this is essentially what it's doing statewide. And honestly, this is what it's been doing nationwide. It's an exponential growth that's going up. It's also interesting to note that methamphetamine deaths are about stable. They kind of flat right across there. Still a major cause of drug-related deaths and something that we don't want to forget about. But fentanyl is really picking up and almost doubling that of heroin-related deaths, and that's just because it's easier to smuggle, smaller amounts, and it's widely available on the streets. So next slide. Well, there's this one option on Google that's called Google Trends, and Google Trends will actually give you information about the number of searches in some geographic area on a specific topic. And this is just an example of Google Trends looking at fentanyl for the state of Washington. And you can zero in on an individual zip code if you want and see where people are searching this. But you can see in the state of Washington, we're really seeing this in Yakima and the Tri-Cities, where it seems to be the most interest in searching for fentanyl. And quite honestly, that's where we've seen a big trend in a lot of the opioid deaths as well. So just a way of kind of studying this, and we compare this sometimes to our data at the Poison Center. How does it correlate with the calls we're seeing? And there's a significant overlap there. Okay, next slide. So treatment basics really goes back to basic life support, basic CPR, with the addition of naloxone. And we have a whole speaker on naloxone tonight, which is just fantastic because naloxone is really the antidote. It really reverses the effects of fentanyl, heroin, Oxycontin, or any other opiate or opioid drug that's out there. So we always think about, circulation, airway, and breathing, CPR essentially. But naloxone, or Narcan is one of the trade names, is really key to reversing these effects. So if we go to the next slide, I just want to show you an interesting thing, because the dose of Narcan that we typically use, sometimes in the hospital we use a smaller amount to just kind of very slowly increase their level of consciousness. But in the field, oftentimes we just use 2 milligrams to wake these people up, or 4 milligrams intranasally. But if you see this slide, the vertical axis where it says percent, that's the percent of receptors in the brains that are occupied by fentanyl. So after a 25 nanogram dose of fentanyl, which is a standard, even smallish dose that I might give someone in a hospital for pain, about 75% of these brain receptors are occupied. So to reverse that, if we look at the naloxone, the Narcan doses, we see to bring that down to less than 10%, you probably need almost 10 milligrams of naloxone. So the point here is that you might need to give more than 1 dose of naloxone to these patients to really stabilize them. But that initial dose will buy you a significant amount of time until EMS can get on site and help you with that. Okay, next slide, please. And with that, I just wanted to thank you and remind everyone that the Washington Poison Center is here to help you 24/7 every day of the year. We even have dedicated backline for EMS responders, so EMS can call us directly when they're on their way to a scene. And so please call us. We can help you get advice. We can direct you to special resources that might be needed, or to give advice to other healthcare providers. So I think that's my last slide, and I just want to thank you all for your time and appreciate it.
Thank you, Dr. Phillips. That was incredibly informative. I appreciate you taking time out of your busy schedule to join us. I do have just one question before you go. Something that I have been asked before and I don't know the answer to. Can an individual become poisoned just by touching fentanyl?
So that's a great question that's involved a lot of research, going back actually many years. And we see this pop up in the press from time to time. It cycles every 3 to 5 years, seemingly. But the answer is that liquid fentanyl can be absorbed through the skin fairly well, and that's why we have fentanyl patches. The powder doesn't absorb very well through the skin at all. So with most what we call occupational exposures, either from EMS, fire, or in the manufacturing of fentanyl legitimately, most dermal or skin exposures to fentanyl powder does not get absorbed through your skin in any quantity enough to really make you lose consciousness. Now, that being said, this is a very potent chemical. You don't know that it's fentanyl when you're seeing a powder and touching it. So the answer is look for objective signs. If they have depressed mental status, they're kind of comatose looking, shallow or no breathing, or very weak and thready pulses, blue lips, give them a Narcan and let us figure it out in the hospital. That's the ultimate answer.
Excellent. Thanks so much for being with us.
You're welcome. Thanks for having me.
Our next guest is Captain Tom Hendren, who has served our community for over 25 years as a member of the Spokane Police Department. During his time with the Spokane Police Department, Captain Hendren has served as a patrol officer, detective, sergeant, lieutenant, and captain. Additionally, he has been a part of numerous specialty teams to include over a decade as a SWAT team operator and member of the SWAT leadership. He spent 2 years as a detective and an additional 6 years as a sergeant working in the department's special investigative unit, which is primarily focused on investigations involving the manufacturing and sale of controlled substances. He currently serves as the captain overseeing the department's investigative division. Thanks for being here, Tom.
Yeah, thanks, Haley, for having me. I really appreciate it. And thanks to the Regional Health District for having me as part of this event.
Absolutely. So, Tom, what is the Spokane Police Department currently encountering regarding opiates and or other illicit substances in our community?
Yeah, so much like the doctor was saying, we are really seeing that fentanyl has really taken over a lot of our street drugs in Spokane. I was just talking to one of my detectives that works in our drug unit, and he said 4 or 5 years ago they were at a conference up in Canada, and they were talking about all of this fentanyl they were seeing up there, and we weren't seeing it. Well, fast forward to today, and that is basically the primary thing we're taking off the street. That and then methamphetamine still it's still very prevalent in our community as well. But those are really the two that we're seeing: fentanyl, the Mexi pills, as the doctor described, and as well as the methamphetamine.
And can you tell me the role that the Spokane Police Department is having in dealing with the current opioid crisis?
Yeah, that's excellent. So there's a lot of confusion out there as far as what our role is. There has been some changes in the law that affects how we deal with people that are just in possession. Our biggest role, particularly when it comes to the opioids, and when we get a call to respond, or a lot of times they'll call it for EMS, law enforcement often is out there and closer. We actually respond quite frequently to potential overdoses. Our officers are all equipped with Narcan. We've had numerous Narcan deployments out there in the street. So our biggest role initially out there on those type of situations is we want to save lives. So that's our biggest role. The other big focus for the department is on the traffickers. So that is where the bulk of my investigative team that works that type of work. We're going after people that are bringing this into our community or selling this. As you know, I view them as really helping to destroy lives and bring a lot of problems to the community. So that's really the two big focuses for the police department right now.
Okay, and then what would you say is the greatest danger posed to the community and individual members of the community that are using the opiates and other illicit substances?
Well, yeah, I've worked drugs either as a detective or sergeant for 8 years. I've seen a lot of tragic stories. I've seen a lot of good people have their lives absolutely destroyed through drug use, and they're hard. It's hard to kick. So from an individual level, I always caution people: you think you can handle it, you think you can control it. These substances are so powerful nowadays. When we're talking about the opioids or we're talking about methamphetamine. And they can immediately take over somebody's life, and somebody can go from having a career, having a life, to being out on the street. It can happen. And I've seen it happen to people from all walks of life. So it's incredibly dangerous on the individual level. As far as for the community, drug addiction brings crime. A lot of property crime is fueled by drug addiction. So that creates a lot of problems for the rest of the community. Additionally, the trafficking brings violence. We've had, going through the years, if you look at a lot of our homicides, there are several homicides that we've had that are related to trafficking, to drug-related situations. So those, on the individual level, on the community level, when we talk about the health costs, as well as the crime and the violent crime, that's how it really impacts every member of the community.
Okay, and then so through your experiences, what members specifically of the community have you seen most heavily impacted by opiates and other illicit substances?
I've seen people from all walks of life. I've seen people who, when people think of a drug addict, they think of somebody living, on Skid Row somewhere. And trust me, there's a lot of our homeless that are people experiencing homelessness that they do have addiction issues that have led to that, or that have exacerbated their situation. But I've seen people that are professionals. I've seen fellow police officers who, through legitimate prescriptions that they were prescribed for a recovery, ended up developing an addiction where they had to seek help to get over that. And so one of my messages to anybody I talk to is, if you realize that you are having those issues, seek help. Because the sooner you seek help, the better. Because if you think you can control it, I've watched really good people destroy their lives because they couldn't control it. And really quick, I wanted to go back on one of the things for the dangers of the community. And it's really for anybody that goes down this road and starts down the road of addiction. If you're getting your drugs on the black market, you have no idea what you're getting yourself into. And we are seeing time and time again, people are purchasing one thing and getting another. There is no FDA that is going into these people's homes and making sure that you've got the proper dose and this is exactly what's in those substances. And we are seeing, like the doctor said, fentanyl is showing up time and time again, and often marketed in drugs that people don't think that's what they're getting. So that is an incredibly dangerous situation. And unfortunately, with that, we've seen situations where users who think they've got a control of it, I can handle it, have actually died almost instantly from the fentanyl overdose. So that is a huge danger. But this can impact anybody. And like for me personally, if I have an injury, I don't want anything prescribed that's an opioid, because I've seen too many good people really have struggles in their life.
Yeah, it's incredible how many people it's impacted, for sure.
Amen.
Well, thank you so much for sharing with us how the Spokane Police Department is actively working to fight the opioid epidemic, and also for touching on the importance of destigmatization. I really appreciate your participation this evening. Thank you.
Absolutely. Thank you. And thank you all for having me. I appreciate it.
All right, up next, we're going to show pre-recorded videos that Assistant Professor of Pharmacotherapy at WSU, Nicole Roden, put together on naloxone and the non-injectable administration of naloxone.
What is naloxone? Naloxone is essentially a medication that is going to reverse all of the effects of opioid medications. It is working on those same receptors. So we have these opioids who are in our brain, they're hugging tight to those receptors, and they're releasing all of those feel-good chemicals. Unfortunately, when we have too much of it, our body starts experiencing overdose symptoms, like not being able to breathe, or having a really low heart rate, or having really small pinpoint pupils and being very drowsy. So when we see these signs in someone, we recognize that this is a job for naloxone. And when naloxone comes into the body and we administer it to our patient, friend, or family member, it is going to kick those opioids off the receptor. So it's going to replace all of those receptors, and it's going to stop any effect from the opioid, which is great. So any breathing that would have been impaired, it's going to reverse it, and we're going to start to see that person breathing again. But any good things like pain management that's been happening with the opioid, it's also getting kicked off, and it's not going to happen anymore. So, is naloxone safe? Yes, this is remarkably safe. It has one of the highest safety profiles as any drugs on the market. but it only works on those opioid receptors. So if there's no opioid, there's not going to be an effect, which is good and bad. So good thing, if it's something else that's wrong with this patient causing them not to breathe, it's not going to make anything worse. But it's only going to work if it's an opioid causing this overdose. So it's not going to work on a methamphetamine overdose. It's not going to work on a benzodiazepine overdose, something like Xanax, Ativan, diazepam. All of those things might look a little bit like an opioid overdose, but unfortunately this medication will only work on opioids. So those hydrocodones, those oxycodones, the fentanyl, and the heroin as well. So then who would benefit from having naloxone in their house or having it on them at all times? Honestly, patients. So anybody who is prescribed a chronic opiate, somebody who has struggled with opioid use disorder in the past, caretakers. So anybody who is taking care of someone or who is kind of living with somebody else and knows that they might be prescribed these medications, is helping them with these medications, or just is aware that they have a substance use disorder past. Family members. So this medication is really safe. So in case kids get into the medication cabinet, grandparents, something's taken that some way it's not supposed to be taken, family members would definitely benefit from having this on hand and being aware of how to use it. Emergency responders definitely benefit from having naloxone on them. Our Spokane Fire Department and police do have this and have training and are excellent at using it and making this accessible to all patients. And then of course healthcare providers. So most notably your pharmacies locally are going to have this stocked and ready to go whenever you do need it. So then that kind of segues into where can I get it? You can get it from your doctor's office. So if you need your doctor to prescribe you naloxone, they can and should be able to do that. You can also just walk into your pharmacy. Most of your pharmacists in Spokane can write a prescription for you for this and get it sent through and all taken care of right in your one-stop shop visit. So definitely visit your pharmacist for that. And you can get it from the health district. So during the needle exchange programs, our health district is awesome at providing resources like this. We also do have a standing order in the state of Washington. So what a standing order is essentially it is going to be a prescription that has been signed for every Washingtonian in the state. All you have to do is either grab it at your pharmacy or print it out at home and fill in your information. Once you get to the pharmacy, they can process that standing order and get you that naloxone right then and there. So that is where you can get this medication. So we have a bunch of different types of naloxone. These 4 that you have pictured on your screen are going to be the most common types of naloxone that we do see. And right now I'm going to walk you through how to use each and every one of them. So Narcan is a little bit newer of a medication. It looks like this little tiny white plunger. So with this medication, again, it's really user-friendly. It can be a little bit more expensive, but most insurance does cover this medication. So you'll see this a little more commonly than we have in the past. For the intranasal naloxone, we have this big portion that's not covered by anything. This is going to be the top of it. That's what goes in our patient's nose. This bottom portion is the plunger. It's really sensitive, so be careful not to push it until it's fully inside of our patient's nose. So we want to grip this device as well as possible, avoiding that plunger here at the bottom. We are going to place it all the way into our patient's nostril until we can't anymore, and then we are going to push this plunger. Once we push this plunger, all of our medication is going to go into the inside of the nose and it's going to enter the bloodstream exactly where we want it to. So if your patient is not breathing, that's okay. We don't need it to get into the lungs, we just need it to get into that lining of the nose. So for this medication, the entire dose of your Narcan is going to go into one nostril. So deliver the full entire dose, pushing that plunger and getting it into that system as quickly as you can, and that's how you use the brand name Narcan. The other way you might see intranasal naloxone is going to be in the form of this kit. So in this kit, it has 3 pieces. The first piece is going to be the medication itself. So it's going to come in this small little vial. It's a glass vial with a colored top. The second piece is going to be its plastic canister. So this is usually going to be bright yellow or bright orange up at the tip to let you know that this is how you're going to deliver your medication. And then third, you're going to have this little cone. So this little cone is what's going to turn that liquid into a nice mist so that we can get all of that medication into the nose, just like that Narcan we did before. So in using this medication, you're going to do the same thing. You're going to get your patient ready, have their nose available for you to put it in, and essentially you're going to take all these brightly colored caps off. So for our little plastic piece, you're going to take the back off of it. It's a bright yellow cap. And you're also going to take the top off of it. So it's just the clear plastic portion right here. The next thing you want to do is you want to take your brightly colored cap off of your glass vial. So this contains our medication, but don't worry, it won't fall out when you take this lid off. It's nice and safe inside of there. And so we want to take that stopper off so we can put it into our plastic device. So in our plastic device, we have this nice kind of flat part that has room for our fingers. This is where we are going to insert in our naloxone. So in the portion that you took off the cap, there's a nice hole there. You just want to push that all the way in here and screw it in until you can't screw it anymore. Once it's pretty secure in there, you'll feel it and it won't keep going and you're ready to go. Now we're going to put on our little cone. So our little cone is called an atomizer, and this just screws onto the other tip of it. So at the very top of it, this is what our assembled product is going to look like. So this allows us to turn this liquid into a mist so it goes into my nose. So when we're ready to give this to our patient, there's a lot more liquid in here than there was in our Narcan. So we're going to put half of it in one nostril and half of it in the other. So we're going to get this nice and cozy all the way up into our nostril, and this one is going to be a little harder to push. So if you don't push hard enough, it's going to come out in a little stream. So I'm going to try and show you here. So that was kind of misty, kind of streamy, but what we want it to look like is a full stream. So give it a good, nice push, and that's going to make sure that all of this is going to get nice and misty so it goes into our nose. So the nice mist is going to look like this. You see that? Nice and misty, and it's not going to just dribble out the nose. It's going to stay exactly where we want it. So we're going to do half in one nostril. Nothing is going to tell you when that half is up. You just kind of have to estimate. You don't have to be precise, you don't have to be exact, just do the best you can. If you're paying attention to it, more often than not, you're gonna hit it right on the spot. So half in one nostril, take it out, and do half in the other nostril. And then you've completed this naloxone dose.
Nicole was unable to join us this evening, but as always, we genuinely appreciate her tremendous involvement with the task force. I'd like to remind everyone that there is a standing order for naloxone in the state of Washington. There is a downloadable PDF available on the Department of Health's website. Next, I'd like to introduce Sean Witcher from Crisis Connections. Sean is a substance use prevention clinician and TeenLink team lead. Sean, could you explain a little bit about what Crisis Connection is and furthermore what TeenLink is?
Sure, I'd be glad to. Thank you for having me here tonight. So Crisis Connections is a crisis line for the state of Washington. Underneath the Crisis Connections umbrella, you have lines like the 211 line, Recovery Helpline, the WARM line, and then coming next year, the 988 number is going to be part of Crisis Connections as well. And TeenLink is a peer support line for teens that falls under Crisis Connections. Excellent.
And when was TeenLink founded?
So TeenLink was founded in 1996. In 1993, a 16-year-old named Audra Letness, she died at the hands of an abusive boyfriend, and a former employee of Crisis Connections, that was their daughter, and so they started the TeenLink line in '96 to give teens somewhere to go when there's an abuse happening or they need to talk to somebody other than a parent.
So then, how can youth access TeenLink?
So TeenLink is free, and it's statewide for Washington State. Teens can call the TeenLink line, and they can also visit teenlink.org and chat in right from the website, or they can text the TeenLink number. It's open from 6 to 10 p.m. every night.
Excellent. And then who's there answering the calls?
So the unique thing about TeenLink is it's a peer support line. So the people that answer the calls are teen volunteers. We trained the volunteers through quite a bit of training, and they are the ones that answer the calls, chats, and texts from the other teens.
So then can you tell me a little bit about what it's like when someone calls, chats, or texts into TeenLink?
Sure. So when someone calls, chats, or texts in, they'll get a teen right away. And the teen will basically say, you know, thank you for calling TeenLink. What's going on tonight? And the teen, it's fully confidential. So anyone that calls or chats in, they don't have to give their name or their information. It's strictly confidential. And from there, they can just talk about, you know, whatever's going on in their life. If they're feeling sad, maybe they're, you know, feeling like suicidal, or they need help with substance use, they can call and chat with the teen about that.
So then who can volunteer and what kind of training do volunteers need to go through?
Yeah, thanks. So volunteers can start as early as age 13. And from 13 to 15, they can volunteer and help with outreach. So they get trained to be outreach. And part of the outreach is to just basically, you know, promote TeenLink, tell friends, you know, tell the school, go to outreach events. And then from 15 to 19, they can work as a phone worker. And so they can be the ones that are taking the calls, chats, and texts and helping other teens. And then for the older youth, if you're 20 and older, you can volunteer as a mentor, and then you can help mentor the teens while they're on the call.
So you mentioned a few of the reasons why folks could reach out to TeenLink. Could you give me maybe a broader list of reasons why teens call?
Sure. Yeah, so a lot of what we hear is what you're seeing in a lot of the reports, like the student COVID survey. So teens are calling in. It could be bullying. There could be issues at home. It could be like abuse, and that could be abuse maybe from parents or like a significant other. Teens are also calling in about substance use, and you know, they're calling in because they're lonely. A lot of LGBTQ teens are calling in because they feel very isolated and alone. So yeah, it's a lot of depression out there, suicide ideation and self-harm, and then also like eating, disordered eating is also pretty common for teens.
So I think it's just incredible that they have peer supports there to connect directly with the teens. But in addition to having that ear to hear these folks out, are there other resources that teens can access through TeenLink?
Yeah. So we have a little booklet called Where to Turn for Teens, and we can send those out to different schools if they want them. You can request those right from our website. And the booklet includes resources for all different types of situations, and they're youth-specific resources. So if they're looking for maybe they're homeless or they're needing food or like education, the little booklet has a bunch of resources in it that we've compiled from the 211 site that's youth-specific. Youth can also go to our website. We're launching a new search part of the website. It's going to be search.teenlink.org. And it's just like the 211 search page where you can put in what you're needing. And the unique thing about that is it's going to filter it just for youth resources. So instead of like a youth or a parent needing to call a bunch of places, seeing if they have youth resources available or if they're able to take teens, all the resources that are going to be in that list are going to be youth specific. So it makes it a little easier to find.
Excellent. And Sean, can you just share with us one more time the website?
Yeah, it's teenlink.org.
Excellent. Awesome. This is truly an incredible resource. I really appreciate you joining us this evening, and I really encourage folks to take advantage of this.
Yeah, thank you so much for having me. Really appreciate it.
All right. So our final guest is Dr. Marion Wilson. Dr. Wilson is a registered nurse and associate professor at the Washington State University College of Nursing. She has also been active since 2018 on the Spokane Regional Opioid Task Force and the Non-Opioid Pain Management Subgroup. She is leading a project by the subgroup funded by the Ray Srudine Foundation and the National Center for Advancing Translational Sciences of the National Institutes of Health. She'll tell us a little more about the project and the work of the task group now. So can you tell us what is the task force working on?
Yes, this group, we have been dedicated now for a couple of years trying to improve access to pain treatments that do not involve medicines. We know that people are being encouraged not to use opioids for their pain, and we recognize that we need to have options for people if we're going to tell them don't use opioids. So this group was really focused on trying to make things more accessible. The pilot project that we're doing allows us to have people test a modality of their choice using Zoom actually to receive a consultation. So originally we were hoping we would have a clinic where people would come in and try yoga therapy, massage therapy, physical therapy, or chiropractic. And they would get to experience that if they hadn't done it before and maybe get some new ideas on how to manage their pain. With the pandemic, we had to switch everything to Zoom. And so now the consultations are being done using technology. The positive thing is that we're finding that these practitioners have such great knowledge about how to help people manage their pain, even without the hands-on approach that they would prefer. They have plenty of information that they can give to these people who have very complicated pain histories for the most part. So that's the prime focus.
Excellent. And so can you tell me at what point a person might think about a non-medicine approach towards their pain?
Really, any time is a good time to think about different ways to manage pain, because with any medicine, you're going to have some risks of side effects. But particularly if you've been on a medicine for 3 months or more, that would be considered entering a chronic phase. We know that long-term use of opioids can cause some problems. They can work really well in the short term, but over longer periods of time, people can develop side effects. They can develop tolerance, meaning they need more and more of that drug to get the same effect. And of course, that can lead to unintentional overdose if they keep taking more and more of the drug to try to relieve their pain. So 3 months is when it's a great time to reconsider the way that you're managing pain and think about other things you can add to your arsenal.
So then what would you say, what does pain have to do with the opioid overdose epidemic from your perspective?
I think we really can't talk about the opioid crisis without talking about pain. And there's a couple of reasons why. One is we know, as some of the speakers have mentioned, some people enter their first use of opioids from a painful condition. Of course, most people will not develop a substance use disorder, but a percentage of people will. Those people at risk for developing substance use disorder who receive an opioid for pain could go on to have a problem with those opioids. There's estimates between 8 to 20% of people could develop a substance use disorder if they're taking opioids for pain. So that's one issue. The other issue is that people who have substance use disorders, and particularly opioid use disorders, often have chronic pain on top of their substance use problem. So they may have a chronic pain or they may have acute pain related to their withdrawal symptoms. They often have depression, anxiety, stress, a lot of things that don't help with pain. So if we're going to talk about substances and opioids, we really have to talk about what we're going to do about pain.
Then what should people do if they or somebody that they know have been cut off from their usual prescriptions of opioids for pain?
This is a really important time to give that person support. It is very difficult for some people to transition away from opioids if they are no longer being able to have access to them to manage their pain. There's been notable increased risk of suicide attempts and completed suicides in people who have had to stop their opioids. So if they are asked to stop or taper their opioids, it's something that really must be done in a setting with a professional who understands how to help people wean slowly off of that opioid or help them transition more quickly. So it's a medical emergency in some cases. If they're having a withdrawal experience because the opioids are not available, that is an emergency situation and they should be taken to get help for that.
And what are some of the things going on in the community to address pain during the opioid overdose epidemic?
I think there's a lot of energy going on around this. Our task force, as I mentioned, we're dedicated to trying to increase evidence to show what is helpful to people and then also to increase access to those modalities. So perhaps setting up a voucher program or something in the future to help people afford some of the things that are helpful. Here at WSU, we're doing a lot of different research on chronic pain and different ways to manage it. We've used some online interventions. We've tested hyperbaric oxygen therapy, and we've looked at the importance of sleep, managing sleep problems, and helping with pain in that way. So there's a lot of things going on, and there is really a lot of hope for people with chronic pain, because we know now there's many ways to address pain. Opioids are one way. They work great in the short term, but long term, many people will need to add something to that or exchange that for a new plan.
Wonderful. Well, Dr. Wilson, thank you so much. I know we're all going to look forward to learning more about opportunities for people to access non-opioid pain management. And thank you for your ongoing commitment to this work.
Thank you for having me. It's been a pleasure.
All right, and that's all that we have for you this evening. I'd like to thank all of the presenters for making time to participate in this year's event, as well as for the ongoing work they put in each day. And a huge thank you to everyone who was able to join live tonight. If you were unable to join with us live, this video will be accessible on the Spokane Regional Opioid Task Force Facebook page, as well as on drugpreventionspokane.org. Thank you.